All right, well then I will turn it over to Josh to introduce today's program.
Our program today is Eva Hawes. Eva is the Translational Research and Policy Analyst in the Washington County Health and Human Services Director's Office. Her role in the County Health Department is to lead measurement and evaluation support and training for all programs and divisions in the department. For the last 9 months, Eva has served as the Data and Quality Assurance Epidemiology Supervisor on the COVID-19 response. She's an epidemiologist and health educator by training and specializes in the measurement of social determinants and the impact on health. She will be sharing the information on the epidemiology of COVID-19 to date. If you can please welcome Eva Hawes.
Hi, good afternoon. So glad to be here. Thank you, Josh, for inviting me. Thank you all for being here. What a lovely introduction to the afternoon. It's so nice to hear all of the kudos and the banter. It's nice to see friendly faces. So I'm going to go ahead and share my screen. So before I get started, I just wanted to let you know that I am pretty informal. So if you have any questions that come up, feel free to either put them in the chat and we can review them at the end, or interrupt me. I'm totally fine with that. So whatever you prefer or however your usual way of working together is. So this afternoon, I'd like to talk a little bit about viral transmission, look at the state of the outbreak in the nation, Oregon, and here in Washington County. And then we're going to talk a little bit about vaccine planning. And it sounds like we have some actual vaccine rollout within the group, so that's very exciting to hear. So the first thing we're going to talk about is different modes of viral transmission. So there are 5 main ways of transmitting virus. The first one is direct transmission. So in this one, we think about actual touching of something. So here we think of sexually transmitted infections or other ways where you're directly transmitting that disease. Vector-borne transmission, so these are things that are transmitted from other creatures to us. So things like West Nile virus, the plague, things transmitted via bugs or mosquitoes. Vehicle-borne transmission, so these are things like foodborne or waterborne transmission, so Salmonella, E. coli, that sort of thing. And the last 2 I want to talk about are droplet and airborne transmission. So both of these are from your respiratory tract. And they can be very confusing. And the difference between the 2 are really about the size of that droplet. And I'm going to show a visualization of what that looks like. It's a little bit busy, but what we're looking at there is on the far left is our sick person, right? So they're talking, coughing, breathing, spitting. That poor next person to them is getting all of these heavy, wet droplets. So the bigger the droplet, the more virus is contained within that droplet. If you're very close to a person and you are getting a lot of those heavy, wet droplets on you, you're getting a lot of exposure to that virus. The thing about droplets is they can be also small and they can float about in the air for several minutes. They can fall and contaminate surfaces. We've heard a little bit about that at the beginning of the pandemic. We weren't really sure what COVID-19's primary method of transmission was. But what we can know is that its primary method of transmission is not in this airborne way, it's in this the droplet transmission. Now, we have learned that it's theoretically possible and certainly has been proven that COVID-19 can be transmitted via the air, but it is not its primary method of transmission. So this is why we want to make sure that that public health messaging between droplet transmission and airborne transmission is roughly the same for those of us in the public and those of us in public health. In hospital settings, that's a very different precaution. But for us, we're talking about the fewer the people together, the better, right? So you are not close to someone who's having these heavy wet droplets. The more distance between people, the better. The less hand-mouth contact, right? So the less we're putting potential sources of exposure onto our mucous membranes, and the more often those are covered, the better. The next thing I wanted to review with you all is something that those of us in the epidemiology world think is one of our tenets. This is called the epidemiologic triangle. This is showing that to continue to propagate in an epidemic or an outbreak or some sort of infection, we need to have this perfect triangle of things going on. So we need to have a host who's susceptible to the agent, whatever that is. In our case, of course, right, that's SARS-CoV-2, the virus that causes COVID-19. And we need to have a good environment for that to happen. So all three of these things being present really leads to these epidemics happening. Where we can interrupt that cycle, we can stop that outbreak from continuing. So if we interrupt that chain of transmission between the agent and the host through immunity, right? That's either enough people getting sick with the virus so that the virus can't spread, or through vaccine. And another way we can interrupt that cycle is making that environment less good for the virus to transmit. So here we're talking about physical distancing, using face coverings, covering those mucous membranes so that we're less likely to infect ourselves. So if we interrupt any section of that triangle, we can stop these outbreaks from continuing. And here I wanted to talk a little bit about the reproduction number, so R0. Have you all heard of this concept? It's been floated around in different articles as this pandemic has gone on. And I really like this visual because I think it really well illustrates how quickly these sort of things can get out of control. So if we talk about reproduction number, that's the number on average, assuming everybody's susceptible to the disease, which of course we all are, the novel coronavirus. If everyone is susceptible, the reproduction number is a number on average that will get sick from one person. So on our visual here, the person in red is sick and they infect on average 2 people. And then those 2 people on average infect 2 other people. And then on average, they infect 2 other people. So you can see even with an R0 of 2, how quickly outbreaks can go from a small cluster to really exponential growth. And that's what we're experiencing here, well, across the nation in Oregon. We started small and then it just goes very, very, very quickly. This last one is looking at the R0 of a few different viruses. The first one on the far left is seasonal influenza, and that's on average, if everyone is susceptible, which we know in the flu season, not everyone is because we often have some sort of cross immunity or vaccine-based immunity. But on average, in a typical flu season, one sick person is going to get between 1 and 2 people sick. For COVID-19, of course, this is ongoing, right? Because we're in the middle of a pandemic, so we don't have perfect data yet. We'll know more as soon as we reach an end, and when there will be an end. We think it's somewhere in the ballpark of 2 to 3. And so if we look back at this one, we can see even if it's at 2, how quickly that could spiral out of control. And if we think that's 3 people, right? So each person is getting 3 people sick, that can just really get out of control very, very quickly. For SARS, which was a few years ago, that was a little bit higher, but that did not expand quite as much as we've seen here in COVID-19. And the last one there that I wanted to bring your attention to is measles. So that's one of the diseases that we typically think of has its primary method of transmission being airborne. And you can see how many people get sick from one person if we're all susceptible to measles. So I show this because one, it clearly shows how quickly measles outbreaks can become a big problem. So if you hear about pockets of measles outbreaks in populations that are either under immunized or not immunized, you can see how quickly that could spiral really out of control. And also to demonstrate that if COVID-19 was truly primary method of transmission being airborne, we would see a lot more people getting sick much more quickly than we have so far. So we're pretty confident that it is droplets, which is slightly easier to take care of, but still very, very transmissible, but not quite as bad as if we had seen an airborne disease. So any questions on that before I move on? Okay. So I wanted to look a little bit at the state of the outbreak. So this map is showing all states and territories within the United States, their incidence rate, so their cases per 100,000. And the reason why we do that is so we can compare roughly apples to apples across state lines. If we only compared case counts, of course, we would see much higher case counts in very densely populated places and less in rural areas, but that wouldn't necessarily mean that they don't have the same level of outbreak happening. So that's why we compare incidence rates. And you can see Oregon, we have historically and currently been among the lower tier of states being impacted by COVID-19. Not that we don't have issues, not that it isn't still a big problem in our state, but compared to the rest of the nation, we have fared better, with the exception of some states in New England over there. So this is looking at all time. And then I want to bring your attention to the last 7 days. So it's just an illustration of where hot spots are. Right now, in the last week or so, it has been California, Arizona area, lots of states across the South. Last time I did this presentation, it was up in Montana, Colorado area. So just looking at where the virus is really active right now. We know California's in a really dire situation.
So Eva, I have a question.
Yes, go ahead.
Sharon. So I had read that as far as case counts, I'd read that there's 2 different ways that cases are counted. And my understanding was that one was like per test. And so let's say myself went in and I got tested and I was positive, and then I went back in 2 weeks and I was positive and went back again and was negative. Those are counted as 3 times. And I read that the state was changing how they were doing it and essentially saying, hey, I'm one person and I'm only counted once.
Yes.
And my understanding was, and I read this article, I think it was out of Willamette Week, and so I'm curious what counting means here. And I'm curious if it didn't sound like it was a standardized way of tallying scores state to state. So how do you measure when states are deciding a different way of tabulating their case count?
Yeah, that's a really great question. So to clear that up, so yes, I think different states are measuring that a little bit differently. This is measured by reports from each state that are mandated to report to the CDC. So this is measured the same way across all of those data. The state has shifted the way they're looking at percent positivity. So the number of positive tests independent of people. So you're absolutely right. So if I went to get tested today and in 3 days for some reason, and I had 2 positive tests, I would be counted twice in that percent positivity measure. And then it's percent positive test over total number of tests. Prior to that changeover, they were measuring percent positive test over number of people tested. And that became problematic as we continue to test lots and lots of people, and especially for serial testing. So when we tested people frequently, either in university settings or in congregate care, so long-term care facilities, as we had more people test negative, they were only counted once. And so our denominator shrunk as our numerator grew. So it looked a little bit worse than it was. As far as counting positive cases, you should only be counted once. So once you're counted as a case, you are counted once unless you have a new infection, which we have seen a handful of those. And each state has a little bit of a different definition for what that looks like. And I think that has been one of the main challenges. Of course, this is the only and hopefully first and only hopefully pandemic in my career as an epidemiologist, but I think it has been very challenging to not have federal guidance on how to measure these things as we go forward. Great question. Did that answer that? Cool. Okay.
I have a question about the spread of the disease.
Sure.
It appears that some of the states with lower population seem to have more cases. So if I look at Alaska or Wyoming, North Dakota, South Dakota, Nebraska, lower population states, Utah, how do they end up with more cases being at, I'm assuming they have more space between people and less people to start with?
Yeah, I mean, I think that's a complicated question with a complicated answer. I think it depends on the jurisdiction. There has been a wide variety of response, I think, at the state level and at the governor's level for each state on how they want to implement measures within, and for better or worse, with however that's looked at. at. So some of the states that weren't hit hardest in the beginning, right when we had these really high spots in New York, especially New York City and California, some other states did not really implement any restrictions. And there's still some that have not implemented many restrictions or any. And those states really saw resurgence over the summer and winter as they slowly dripped in. If we remember that visualization of how quickly something can get out of control once it's in your state, I think that's what they've experienced. And that's another good illustration for why we want to compare incidence rates, right? Because if we were only comparing case count, California and New York would look much, much worse than other parts of the country, even though in relevance to their population size, they may not be.
Eva, I have a question, and my question is actually two, and it's more, and this may be later in your presentation, so I'm sorry if I'm jumping the gun, but can you address, I've heard people say to me, everybody who's dying is being listed as COVID death because then the doctors get paid more and the hospitals get paid more. How much of that is reality and how much of that is fantasy?
Well, that is not in my presentation, so no worries on asking that ahead of time. I do not think people are getting paid more to call a COVID death a COVID death. That there is some truth, though, to I think some of the confusion around how do we classify death related to COVID. And I think that's one of the challenges we've had because that's different state by state. So in Oregon, if somebody dies and has had a positive COVID test within the past 60 days, independent of reason, they are coded as a COVID related death. And the opposite is true. So if they died and we didn't know that they were COVID positive, but if a person on their death certificate or on their autopsy said this looks like it's related to COVID, then they would be counted as a COVID related death. Other states have done that differently, and that's how we are counting COVID related deaths. So I think that's challenging. In Washington County, because we have partnered with our local medical examiners, actually within our public health division, we're able to analyze all of our actual deaths within our county residents to see whether or not it is sort of this artificial, I tested positive a month ago, and then I died in a car crash, or if it's truly related to COVID. And we have seen that all of our deaths, as of, I want to say last month or so, were directly related to COVID. So I think that there is some confusion and some truth to that, but I highly doubt that anybody is making extra money. Okay, so let's look at statistics for Washington County, and please, this is lovely, so please do keep interrupting me with questions if you have any more. This is showing the case count epidemic curve. So this is something called an epi curve. Over time, from the beginning of the pandemic until just a couple days ago. And this is only for Washington County cases. We were the first county in Oregon to have a case of COVID-19 on February 28th. You can see it kind of trickled in. We hit a little curve here in the middle of the summer. It felt really big at the time. And then we just surged up in October, November, towards the end of the year. And we're still averaging somewhere between 150 to 300 cases a day, which is just a huge amount of people getting sick and having and public health work to investigate those cases and figure out how do people get sick, how can we stop that from spreading. It is very, very challenging to mitigate that at this point because we have so much community transmission that people may have multiple exposures, and it is very, very difficult for us to identify which is the one that made people sick. But as we continue to see the vaccine curve go up, and we're hoping to see the case count curve come down. We'd like to see that happen before the vaccine curve comes up, but this is what we monitor every day.
Eva, this is Janine. I have another question.
Yes, please.
How it seems that Governor Brown was like rechecking these curves and making choices about every 14 to 20 days. And it feels like it's been 1,000 years since she's decided whether or not Washington County is ground zero for the COVID or not. And I have an office that is public facing. And my understanding is the county regulation is I have to lock the door to my office to the public. And so when is that going to be reevaluated, and when are those restrictions going to come off businesses like myself?
That's a great question. So that you're right, it has felt like 1,000 years. The Oregon Health Authority, our state public health department, has changed the way they've looked at risk categorization for each county several times throughout the pandemic. The most recent one, and I do apologize, I don't have a slide of this in here, but I can certainly share this deck and add a link to that, is looking at the incidence rate. The idea was to make this a little bit simpler. So they're looking at the incidence rate, the percent positivity, using that new calculation that we talked about a minute ago, where it's percent of positive tests over total tests, and assigning a risk level based on that. So Washington County, we have been in the extreme risk category since the beginning of that measurement, which I want to say was in November. We remain in that category for next week as well. And we will until we see those case numbers come down. And it is definitely a very, very challenging thing to navigate between keeping people safe and allowing the economy to continue. So I hear you. Okay, so I just wanted to show a couple of statistics. There are a host of things we could talk about. And if you are interested in more information, I'm certainly happy to come back and dive deeper. But what I wanted to show here is just a couple takeaways from what we see in Washington County data. So this is looking at the percent of cases and the percent of hospitalization. So the case count percent is in the blue line, and then the green line is the percent of hospitalizations. So you see those two peaks there. So what we're seeing is folks in the millennial generation, so people between the ages of 20 roughly to 37 or so, have the highest case count. They're more likely than any other age group to be infected with COVID, but they have a very low rate of hospitalization and death. That flips for our older adult populations who are less likely to get sick, but when they do get sick, they're more likely to be severely ill or die from the disease. And so certainly some concern we've seen over the pandemic. This has dramatically shifted from the beginning till now. In the beginning, we saw those polls really were very, very different. But we know that this is the millennial generation is in the workforce, right? So they may potentially be exposing other folks. And so we're hoping to see that percent come down to protect our older populations in particular. And the other thing we're seeing within Washington County is COVID-19 has really put a spotlight on disparities that we have known have existed for quite some time, particularly among our Hispanic or Latinx populations. So we're seeing roughly 50% of our cases in people who identify as Hispanic or Latinx, where that population makes up about 17% of our total population. And so if we were to see the case count to be distributed based on the population size, we would expect to see 17% when we're seeing actually 50%. So we're seeing definitely a higher disparity here. Lots of work has gone into this area to try to mitigate this, but we continue to see that here and we continue to see it grow. Oh, before I move on to vaccines, so good news. Any questions so far? I'm just eyeing my time too. Okay. So we know that both Pfizer and Moderna vaccines are being administered in Oregon since mid-December or so. Oregon started doing second dose vaccines late last week. So that's pretty exciting to see. It's very logistically challenging for systems and for people because you have to get that booster. I believe Pfizer is 3 weeks and Moderna is 4 weeks. maybe folks who got the vaccine, fact check me on that. Excellent. Okay. Which is confusing right away. And making sure people get their boosters is really critically important. You are fairly protected after your first vaccine, but not entirely. And so that has been logistically challenging. We know that there are some side effects to the vaccine, fatigue, headache, myalgia, so chills and body aches, tenderness or pain. And it seems to be, we're seeing more reports of those than in other vaccines. It also could be that there's a lot of awareness around that. There is a mandatory 15-minute observation for everyone, since we have seen some very minimal severe reactions, but there have been severe reactions, so they're being monitored after the vaccine. For anyone who has had a severe reaction to a vaccine component in the past, they're asking them not to be vaccinated or to have a longer observation time. And I just wanted to show a screenshot. This has a link in it, so if you wanted to play around with it yourself, you're welcome to do so. This is showing the total number of doses administered per day. So the total, and this was as of what, 1/11, which was a couple days ago. So we have 104,000 doses administered. About almost 100,000 people have been vaccinated in Oregon, which is great, but not quite enough. And that is for the statewide. And then we can actually see in Washington County how many people have been vaccinated, how many people have been fully vaccinated, and where that looks. On the state website, you can also see additional information by demographics, so age and race and gender, I believe.
Hey, Eva, I'm sorry. Well, you're going to get to it on the next slide, but I had some friends that I'm aware of that went all the way to Salem to get their vaccinations. I don't know why they couldn't get them in county, and I'm nothing on this list. I'm like phase 15 or something. So why do I have to wait till then to get my shot? Can you talk about that?
Yes. And I should say too, late yesterday afternoon, this shifted a little bit again. This has been an ever shifting landscape on vaccine, but the federal government released more vaccine to states, or released the ability for states to request more, and opened up the recommendations for all populations over the age of 65. So this is now out of date, but will be updated very shortly. So right now, I'll just walk through this and then I'll answer your question. Right now we're in phase 1A still, so making sure that all people who work in hospitals, urgent care, skilled nursing facility, our first responders have vaccine. Then the next step in that is residential facilities, so congregate care, other adult foster homes, healthcare providers and residents, hospice, people working in a correctional setting, so really high risk groups. So groups we've seen a lot of severe illness and death in. Phase 1A and group 3 and 4 are looking at other sort of healthcare providers, non-emergency medical transport. People have more contact with others, so looking at public health workers who have contact with people. So not me, I have contact with my household. Death care workers, so people have more exposure. And then just last week, was it, or maybe a week and a half ago, Governor Brown announced that she was moving childcare providers, school teachers, and district staff ahead of other groups to be vaccinated. And this again may shift based on the federal guidance that we just learned about. And then as we get to phase 2, which is more the general population, we're anticipating sometime in the spring or summer. And that's really dependent on logistics of being able to vaccinate a lot of people and supply. So can the drug companies manufacture enough vaccine to be able to ensure that people get the first vaccine and the following vaccine in that short time period? Yes, Salem, I want to say Salem Fairgrounds last weekend had a very large vaccination event for folks who are in the phase 1A. I don't know off the top of my head if that was only for group 1 or group 2 as well, to be vaccinated. And I do apologize, I'm not the vaccine expert, so I don't know what plans we have going on within Washington County, but this link here is live, and so it has all the up-to-date information that we have. So if there are any vaccine events that are being planned, those would be available on that website. And my understanding is that most people will be vaccinated through their healthcare providers or through pharmacies. I know that through the federal government just yesterday will expand that pharmacy access directly. As to why one group over the other, luckily that is not my decision to make. My understanding that is really based in the amount of morbidity. So how many people are getting sick and how severe are they getting sick, and prioritizing those groups over folks who may not get as sick. And that is, of course, on average, right? Because every person has their own experience with the disease. Even folks in the younger generation can get very, very severely ill or pass. Okay.
Hey, Eva, this is Blake. I have a question. My wife is an elementary school teacher, so she obviously found out yesterday that she's among the next step for receiving the vaccine. At the same time, Governor Brown put out a tweet that said that people should be patient and should not be contacting their healthcare providers yet to find out how to get the vaccine.
Yeah.
How are people finding out the method and the process that they will be able to get the vaccine?
Well, that is a great question. I don't know how school districts are handling that, or if they're holding vaccination events for their staff and their teachers. I don't know how that looks. I think, and I couldn't speak to Governor Brown's plans, but my understanding is that there will be a lot of communication when it's each person or each phase's time, I suppose, for lack of a better word, to go next. And right now with that announcement from the federal government, we don't have the vaccine to be able to open that up yet anyway. So we have to wait for that allotment to come in, and I do not know how they're planning to roll that out. Okay.
Do you mind going back to the very first part about the transmission? And you said it's if I've probably misunderstood you, that it's not airborne, it's droplet borne. So, are we talking pretty fine line of what you call it? And people ask about mask wearing and not mask wearing and that sort of thing. So
yes, absolutely. Yeah, I think that the nuance between droplet transmission and airborne transmission for those of us in the general public or in public health is not a lot different, but in hospital settings or in healthcare settings, it is a lot different. What we're looking at is that droplets can float in the air. So you can theoretically, and people have been infected through far-reaching droplet transmission. And that's where that 6 feet rule came from, right? We think that droplets fall between 6 feet. Of course, each time it's a little bit different. So on average, though, we think that that's the most protective. You're less likely to get sick and you're less likely to infect other people if you are wearing a face covering. So if you're wearing something that's protecting your mucous membrane, so you're not touching your face, your eyes, your nose, your mouth, and if you were to cough or talk loudly around people, you're less likely to spread those droplets. So that's why we're really recommending that universal precaution of just wearing a face covering to stop that transmission if it was to be possible. And because we're seeing enough people transmit the disease before they feel very ill, and we want to make sure that we're protecting as many people as possible. And reminder, it feels very scary, but most people do not get very severely ill and recover just fine. But when you don't, it can be very, very serious. Does that answer your question?
well, sort of. Looking at the drawing, that if I'm less than 6 feet away and carrying on a conversation over the kitchen table and some droplets fall on the kitchen table and the person leaves and I don't clean the kitchen table, am I more likely to get the virus and through the kitchen table contact or through the air?
Well, you're more likely to get the disease if you're not wearing that protective equipment. So I don't know. the droplets don't live very long on contaminated surfaces. You're more likely to get it if it touches you or your mucous membranes. However that happens, if it's through a droplet falling on you that you can't see, or if it's through you touching a table and then touching your nose or mouth. Either way, that is going to provide a source of infection.
So Eva, I have a question. This new strain that, or new variant that came over, they're talking about, does it change any of these parameters?
Good question. So what we understand so far from the new variant is that it is somewhere in the ballpark of 50 to 70% more transmissible. So you're more likely to get infected, but we don't see that you're more likely to get very severely ill or die. So I don't anticipate it will change any of these public health precautions, except for reinforcing that these are really necessary. And what we've seen is that we're not expecting that to have an impact on the vaccine so far. It looks like it is a mutation on the spike protein, but that the vaccine is designed for that. So that they build in space for vaccine or viruses to mutate, because that's sort of what they do. So we are very optimistic that it won't impact the vaccine. So if we can get more people vaccinated more quickly, we can potentially outrun that. But yes, good question.
Thank you.
Why has Oregon been so slow compared to other states?
Gosh, that's a great question. I don't know if I have an answer for that. I mean, I know I don't have an answer for that. I think there have been massive logistic challenges with relying on the healthcare systems to vaccinate their folks when they don't have extra capacity to do that either. I think there's been confusion in messaging all around. But I don't have a great answer. Yeah, last I looked, we were like in the bottom tier, the last 5%.
I've got friends and relatives in 4 or 5 different states, and they've all had their shots.
Yeah, I wish that was better.
Yeah.
Oh, I do realize I'm at time. So I want to be respectful of your time, but I'm happy to answer additional questions if you have any, or here, I'm going to go to the end. I will send out this slide. Josh, can I send that directly to you? My contact information is here, so feel free to reach out if you have any additional questions, or if you need resources or access to any of these data that we talked about. I will add a link to the public health metrics so that you can see where Washington County is at as well.
Well, Eva, one comment that I heard on one of the TV shows that I watch, you missed one of the major pandemics in the world that was going on in the early 20th century, and that was tuberculosis.
Yes, absolutely. It's still going on.
Mm-hmm.
Thank you so much, Eva, for coming and giving us these updates today. It's definitely been part of all of our lives for these past 10 or 11 months, and I'm really looking forward to all of us being able to have access to the vaccine and return to life as normal. And I think we'll all be more appreciative of the freedoms of just moving around and getting together that we all miss so much. So thank you.